Good morning. Thank you so much for joining us and for lending your expertise to the Health Policy Institute of Ohio's Equity Advisory Group. I'm Reem Ali, the Vice President of Healthcare System and Innovation Policy at HPIO, and I'll be facilitating HPIO's work around health equity and the work of this advisory group. We are very excited to be convening this group and really thank you in advance for both your interest and participation. We're experiencing just a little bit of technical difficulty, so if you could hold on for just a second. So for those of you who are not as familiar with HPIO, we are a small nonprofit organization, and our mission is to partner with policymakers and other stakeholders to provide the independent, nonpartisan information analysis needed to create evidence-informed state health policy. HPIO was founded in 2003 by a number of foundations from across the state, who, along with the organizations that you see here, provide us with the core funding for the work that we do. I mentioned that we are actually a small organization. We are a staff of 9, and you can see our staff here. We all work very closely together on our various initiatives, projects, and publications. So while I'll be leading this work, you will likely be seeing or hearing from other staff at HPIO as well. Here is the agenda for our webinar today. I'll be reviewing the background and purpose of the Equity Advisory Group, the equity products that the advisory group will be informing, and then we'll move on to a discussion of current definitions of health equity. Today's webinar is really meant to set the stage for the work of the advisory group and our future discussions. We do have an equity advisory group page that is currently live on the HPIO website, so you can go to www.hpio.net and click on groups, and you will see that the Equity Advisory Group is listed under that tab. The page provides information on the Equity Advisory Group and will also include materials from advisory group meetings. Materials for today's meeting are already posted, and we will post a recording of today's webinar later this afternoon. If you have any questions about meeting logistics for today or for future meetings, please feel free to reach out to Alana Clark-Kirk. Her information is here on your screen. The Equity Advisory Group really builds upon an equity work group that we convened to help inform our work around the Health Value Dashboard. The dashboard is a scorecard that we developed in conjunction with other stakeholders that were a part of our Health Measurement Advisory Group to track Ohio's progress on health value. We define health value as a combination of improved population health outcomes and sustainable healthcare costs. More specifically, the Dashboard Equity Work Group helped in the selection of metrics that are included in the 2017 Dashboard Equity Profiles. Within the equity profiles, we provide disparity ratios across a core set of measures from the dashboard by race and ethnicity, income level, education level, as well as disability status. In 2017, HPIO also hosted a series of regional forums around health equity, where we highlighted data on disparities and inequities, as well as shared evidence-based strategies that can be implemented to reduce health disparities. So we're building upon this work as well. Again, we are very excited to be able to focus more on health equity in 2018. As of yesterday, we had 65 stakeholders who had joined HPIO's Equity Advisory Group. Some of you may have taken part in HPIO's Dashboard Equity Work Group or served as a member of the overall Health Measurement Advisory Group, or other groups that HPIO has convened and that have addressed health equity issues, such as the Social Determinants of Infant Mortality Advisory Group. So I just want to take a moment and thank you for your continued support and participation in this work. We hope to build on our previous convenings through this Equity Advisory Group. And I also want to share with you that we have a very diverse group of stakeholders taking part in this advisory group. And you can see the different sectors here on the screen. We have a lot of folks that are very knowledgeable about health equity, as well as experts from the social drivers of health, such as housing, employment, and social service organizations. We were very intentional about reaching out to these sectors that you see highlighted in red, those sectors that are outside of the health care system and public health network, to be a part of this advisory group and inform the work that we will be doing around health equity. We are convening this equity advisory group to help bridge the gap in knowledge and understanding around health equity, and to provide a forum for developing more consistent and persuasive messaging to policymakers. Here you'll see the objectives that we have listed for the advisory group, which include coming to consensus on a shared definition of health equity, informing development of a health equity resource webpage and publication, and then advising on the development of a key messages fact sheet that will provide more consistent and persuasive messaging to policymakers around health equity work. While we may find value in continuing the work of this advisory group for a longer period of time, we have set some key dates and deliverables over the next few months. We have scheduled 2 more meetings of the advisory group in February and March, and you can see those on your screen. These will be in-person meetings here at HPIO. We will provide a call-in option to these meetings, but do really strongly recommend that if possible, you attend in person, since we will be having some small group discussions and doing some consensus building. We also will likely hold a 4th meeting and will notify you as soon as we have selected that date. I also want to make you aware of a conference that is hosted by PolicyLink, an Equity Summit in April that will be hosted in Chicago that some of you have already expressed interest in attending. There is a delegation of about 75 stakeholders from Ohio that will be attending the conference, which has been formed by the Convergence Partnership. HPIO will be attending the conference as part of this delegation as well. If you are planning on attending the PolicyLink conference and would like to be a part of this delegation, please feel free to let me know. You can send me an email conveying your interest. We do plan to apply any learnings from the conference to the work of this equity advisory group. And as I mentioned, as part of the objectives that we have, we do plan on developing an equity resource webpage and publication. Tentative release date for the resource page is February, and we'll talk a little bit more about both the resource page and the publication in a bit. We plan to release the publication in May, and then also the equity key messages fact sheet in May or in the early summer. All of these publications will be informed by the equity advisory group. Again, these are tentative dates, but we do want to give you a sense of our timeline over the next few months. Now, before we dive into the work of this group, I did want to take a few minutes to highlight why the work of this advisory group is so important. The information that I'm going to share may not be new to many of you, but it really is at the crux of why we are convening you all here this morning. We generally frame the discussion of health equity around both health inequities and health disparities. These two words are often used interchangeably, but really are two separate and distinct concepts. We need to address both health inequities and health disparities to achieve health equity in Ohio. Health disparities we think of as the differences in health status or outcomes between population groups. These include differences in outcomes around chronic disease, infant mortality, and premature death. We see some very sobering disparities here in Ohio across many population groups. For example, in 2016, Ohio's non-Hispanic Black infant mortality rate was 3 times as high as that of the white rate. In HPIO's Health Value Dashboard, we estimated the impact of eliminating a disparity between the group with the best outcomes and the group with the worst outcomes on a measure. Here, you see an example related to secondhand smoke. We estimated that nearly 127,000 children in Ohio would not be exposed to secondhand smoke if the disparity between low income and moderate to high income Ohioans was eliminated. Again, looking at disparities by income level, we found that diabetes, obesity, hypertension, and tobacco use were all more common among lower income Ohioans than those with higher incomes. You'll note here that the rate of reported diabetes is more than twice as high for those with incomes below $25,000 than those with incomes above $50,000. There are also striking inequities in Ohio, which are the underlying drivers of health disparities. Inequities are attributed to differences in the distribution of social, economic, environmental, or healthcare resources. This includes differences in access to education, housing, healthy foods, and clean air. Inequities are often the result of systemic, historic, or unjust structures, policies, and norms that then result in health disparities. You'll see here on this slide, children in Ohio living in poverty by race and ethnicity. Poverty is a key driver of health disparities. If this inequity was eliminated, we estimated that more than 130,000 Black children in Ohio would not be living in poverty. Another factor contributing to inequities and disparities that we see is residential segregation. And here in this graphic, what you see is that all 7 of Ohio's largest cities are on the highly segregated end of this continuum. Now, to put these disparities and inequities in context, in HPIO's Health Value Dashboard, Ohio ranked 43rd on population health and 31st on healthcare spending out of 50 states and the District of Columbia. Our health value rank, a composite measure of our population health and healthcare spending ranks, equally weighted, and again relative to other states and the District of Columbia, we ranked 46th. And that puts us right in the bottom quartile, which means that in general, Ohioans are living less healthy lives and are spending more on healthcare than people in most other states. So you take this information along with our information on health disparities and inequities in Ohio, and it becomes very clear that in order for us to improve our health as a state and have a healthier population, we can only achieve that by addressing health disparities and inequities and achieving health equity for all Ohioans. This is a wonderful quote from Stephen Wolfe, who is the director of the Virginia Commonwealth University Center on Science and Health, that denotes that health is more than health care, and that the same holds true for health equity. When we talk about health equity, we have to address all of the factors that impact health, including clinical care and health behaviors, but also our social, economic, and physical environment. So throughout our equity advisory group discussions, we'll want to make sure that we do keep a strong focus on this. I am sure that many of you have seen this image before. This is an image that's commonly used to demonstrate the difference between equality and equity. Here you have 3 people trying to pick an apple from a tree. The crates represent the resources and programs each person has access to, all sitting in the context of a person's social and economic environment. Only one person in this graphic is able to pick the apple, and you'll note that each person has the same size crate, all equally distributed. This second image shows the same people, but the resources and programs have been allocated in a way to take into account the disadvantaged positions each person has started from. The idea here is that when we talk about achieving health equity, we really need to ensure that we are taking into account that people are starting from disadvantaged positions, and that we will need to more aggressively target resources and strategies to address the needs of these individuals to ensure that we can improve their health along with the health of others. All right, so now that I've set the stage for our work and shared some information that I'm sure that you all have been familiar with, I'm going to discuss two of our planned deliverables, the equity resource webpage and the equity publication. Again, the resource page and publication are meant to serve as actionable resources to inform the work that you all are doing around health equity and to share with policymakers and other stakeholders working around health equity in our state. An outline of the resource page was shared with you in the meeting materials for this meeting. I believe that you have also the materials as an attachment, both in your Outlook invite and as part of this webinar as well. I hope you've had a chance to review the resource page, and I'm going to just outline some of the sections that we plan to include. We will have a section on data, Ohio data on disparities and inequities, both from state sources as well as national sources such as county health rankings and roadmaps, and other national organizations that do disaggregate data either at a local level, by race, ethnicity, income level. So we do plan to have a section in the dashboard, on the resource webpage that outlines data on disparities and inequities. We will also have a section on strategies to achieve health equity, and here the focus will be on strategies that are evidence-based. We do have a set of strategies already in our state health improvement plan that we will share, and then we'll be looking for other strategies as well to share on this resource page. We will also be providing information on statewide and community-based organizations that are working on health equity issues in the state. We will include a survey on the page that allows other organizations from Ohio to provide information so that they can be listed under this section as well. And then finally, we'll include a section that provides resources from national organizations on health equity. This is, again, a draft outline of what we plan to have on the equity resource page. And for those of you who are able to review the resource page ahead of time, it would be wonderful if you could take a moment to provide us with some feedback. If there's other information or resources that you think would be helpful to share on the health equity webpage, please feel free to type them in the chat box right now. And if you have not had a chance to review the resource page outline as of yet, please also feel free to email me after this webinar. We would like to get feedback by February 2nd so that we can make sure that the resource page is ready to go later in February. So if you can get that feedback to me by February 2nd, that would be wonderful. But again, if you have any information or other resources or suggestions for the resource page, please feel free to type it in the chat box now or email me after this webinar. Now, within our equity publication, which we plan to release in May, we will be focusing on these three components. We will highlight our consensus definition of health equity and related terms. We will also have a section highlighting data, again, on disparities and inequities that also identifies data challenges around the evaluation of health equity. And then we will have a section in the publication that focuses on evidence-informed policies, programs, and strategies to advance health equity. This includes identifying key characteristics and elements of actionable strategies that can accelerate and sustain the achievement of health equity with a specific focus on addressing the social determinants of health. We would like to, if possible, provide specific examples of evidence-based programs, strategies, and policies that can be implemented to reduce disparities, inequities, and move towards achieving health equity both at the state and the local level. We would like to provide examples of effective programs currently being implemented in various regions of the state, and then also provide state and local level policy options for advancing health equity. Again, we will provide you with the opportunity to give feedback on the publication as we draft it. So we will certainly be keeping you informed, and all of the discussions that we have throughout the advisory group meetings will be informing the publication. All right, now I'm going to move us to our discussion on a consensus definition of health equity as part of our advisory group work. Okay, all right, so what we noted is that stakeholders across sectors in Ohio do not really share a common definition of health equity and often do not share a common understanding of how to achieve health equity. We found that this lack of consensus and understanding can really result in inconsistent and sometimes ineffective messaging to both state and local policymakers, and can really serve as an impediment to engaging in more productive and actionable discussions to advance health equity through policy in our state. With the help of this advisory group, we really want to focus on developing a shared definition and understanding of health equity that can inform our work across the state and that can be, most importantly, communicated effectively to state policymakers. And again, I just wanted to remind everyone that our focus is going to be on communicating and messaging to state policymakers and providing actionable resources that can then be provided to policymakers. Now here we have an illustration of what's known as the parable of the blind man and the elephant. And I don't know if you all are familiar with this, so I'm going to share a little bit of background and the story around the blind man and the elephant. So a group of blind men heard that an elephant had been brought to town, and they did not know its shape and form. They used their sense of touch to learn. The first person felt the trunk and described it as a snake. Another touched the ear and described it as a fan. A third person touched the leg and called it a pillar, like a tree trunk. And as the story goes, each person felt the elephant and saw something different. This parable has been used to describe situations where people really have different perspectives and look at things differently. And we feel that health equity is one of those issues. So here we have an illustration of health equity as the blind man and the elephant. And we have all these sectors that are working on health equity issues, but they may be focusing on something different when it comes to health equity. The same holds true at the national level. We have many organizations that have their definitions of health equity, often similar, a little different. So again, this graphic is just meant to illustrate that we really need to be communicating with one another and coordinating both our work and our messaging in order to achieve health equity for Ohioans. In your meeting materials, you also received a compilation of various definitions of health equity and related terms. So again, I hope you did have a chance to review this packet, but if you have not had a chance, we will certainly give you an opportunity to provide feedback in later discussions. The top 3 definitions that arose from our roadmaps to health equity forums, we had folks get into small groups and rank their definitions, and the top 3 were the ones that you see listed here on your screen. One from the Office of Minority Health, the other from the Prevention Institute, and then the last one from the State Health Improvement Plan. Now, I'm going to ask you to respond to a few poll questions that will help get us thinking about these definitions and help inform our discussions in our next meetings as we work to come to consensus on a shared definition. We will not be making any definitive decisions today with these poll questions, but really just want to use your insight and feedback to get some initial conversations going around a consensus definition. For this first poll question, keeping in mind that we are focusing on messaging to policymakers, we're going to ask you which of the definitions you think would resonate most with a policymaker. There are a set of 8 definitions in your packet. We've split up the poll question into 2, so you will see the set of first four here on your screen now, and then a second set following this poll question. So we have the World Health Organization, Centers for Disease Control, the Office of Minority Health, Health and Human Services, and National Academies of Health. We also have a definition from the Prevention Institute, the Robert Wood Johnson Foundation, the Health Equity Institute, and the 2017 to 2019 State Health Improvement Plan. If you favor one of the definitions that you see on your screen now more than the others, go ahead and respond to this poll. If the definition that you favor is not one of those that are listed on the screen, then just wait for the second poll to respond. Now, I'll give you just a few more seconds to fill out this poll. Again, this information is in your meeting materials packet, which is now on the Health Equity Advisory Group webpage on our site, and also within the Outlook invite. So let me share the responses that we have now. And it looks like in this set, most of you favored either the World Health Organization definition or the definition from the Office of Minority Health. Okay, all right, so let's go on to the second set of definitions. Again, I'll just give you a few seconds to make your choice. And again, we're thinking about which of the definitions would most resonate with a policymaker. All right, and I see the results that are coming in, and so we'll share that with you all. And it really looks like many of you favored the Robert Wood Johnson Foundation definition, and then followed by the Prevention Institute definition. So you can see there's actually a great deal of variety in the responses that we've gotten on which definition that you favor most. So I'm sure we're going to have many more conversations as we try to come to consensus on really a definition that can be shared with state policymakers and that is more actionable. All right, so here you see a word cloud of different terms that we found across the definitions of health equity. But we also did identify that there are some common elements across these definitions, and you see those here on your screen. So we have the highest level of health. Many of the definitions spoke about achieving the highest level of health or full health potential. The definitions also talked about individuals having a fair and just opportunity to achieving good health outcomes. Many of the definitions also discussed a fair distribution of resources, so across population groups, a fair or even distribution and allocation of resources, and then removing obstacles to health and inequalities such as poverty, discrimination, and lack of access to resources. And then finally, many of the definitions spoke to an elimination of disparities or the absence of avoidable differences across population groups. Now, again, thinking about our policymakers and which of these elements you think might be most important to emphasize when we're talking about health equity and defining health equity, I'm going to have another poll question for you here. So thinking about policymakers, which elements of the definition do you feel are most important to emphasize? Is it highest level of health, fair and just opportunity, fair distribution of resources, removal of obstacles or inequalities, or elimination of disparities? And you can choose up to 2. We're going to use the honor code here. Please do not choose more than 2, but we want to see what the top 2 elements are that you have selected. And I'll just give you a few more seconds to respond. All right, so we're going to go ahead and share the results. So the majority of you have really identified. I lost my screen here, so just bear with me for a second. So it seems like most of you have identified removing obstacles and inequalities such as poverty and discrimination and access to resources. And then the other element that you all feel is important to emphasize is having a fair and just opportunity to achieve health. So that's great to see that feedback, because I think it'll be important as we think about a consensus definition to then make sure that we highlight those elements. Now, as we're thinking about a consensus definition, we want it to be clear that we do not think it's necessary to come up with a new definition. If there is a definition that everybody feels is really good and would be actionable for state policymakers and other local level policymakers, then we certainly would want to go with that. But do want to give an opportunity for folks on the advisory group to give additional feedback if they feel like the current definitions just are not sufficient. All right, so moving on to, again, another poll question. We do recognize that there is a tension across these definitions, that some of the definitions are much more comprehensive. They include many more elements. Others are much more concise. They favor brevity. And so first, thinking about what type of definition would be most useful to you in your work, we'd like you to identify, do you think one that would be more comprehensive is most useful, or one that is more concise? And again, I'll give you a bit of time to answer that. And depending on your organization, you may favor one or the other. I know here at HPIO, we tend to internally favor things that are a bit more comprehensive. But as we communicate to folks externally, we do tend to favor definitions that are a bit more concise. All right, so I'm going to share the results with you now. And it's actually really interesting, because what we see is that there is a 50-50 split. So 50% of you favor a concise definition, and 50% of you favor one that is more comprehensive, which, you know, if I would have guessed, I would have said the same thing. I would have guessed that you probably would have said 50-50, but it's really interesting to see those results. All right, now I'm going to ask you to, outside of your organization, think about what type of definition would work best when sharing with a state policymaker or a local level policymaker. Is it one that is more comprehensive, that has more information about these various elements, or is it one that is more concise? I'm hoping that there's a little bit more similarity between your responses this time. It would certainly make our work a bit easier going forward as we think of a shared definition for state policymakers, and just sharing the results here, and it is. So 87% of you have indicated that for a policymaker, a more concise definition would be most useful and helpful. And so we will need to keep that in mind as we have our discussions around this shared definition of health equity. All right, so we are going to move on to what some of our next steps will be, and hopefully get you all out earlier than planned through this initial webinar. So as far as next steps are concerned, we do have that next meeting date set on February 22nd from 10 to 1 p.m. and that'll be an in-person meeting at HPIO. We are planning for some small group work. So again, if you're able to attend in person, that's preferable. If not, we will have a call-in option. It just may be difficult for you to hear what's going on in the room and participate in those small group meetings. As we're thinking about the publication that we'll be putting together, that you all will be informing, if you can begin to email me examples of effective programs that are currently being implemented throughout the state to reduce disparities, inequities, and move towards health equity, that would be wonderful. We also ask that if possible, you include examples of program evaluations for these examples. And then also, again, please feel free to email me any additional health equity resources and information to share either within the equity resource webpage or that you feel are important to inform our future discussions and the equity publication. I do want to give folks an opportunity to ask questions. So if you do have questions about the work that we'll be undertaking over the next few months, again, we are very, very excited about all of this work, then please feel free to type that in the chat box. All right, so I'm going to, I can't see. All right, so I'm going to have one of my colleagues help me see the questions here since my screen has disappeared. Let's just bear with us for just a minute. Okay, so many of you have really given feedback on some of the definitions. We appreciate that. But it doesn't look like anybody has any questions. All right, so one of the questions is, did you use some criteria for listing the statewide and community-based organizations that will be listed on the website? No, we did not use any specific criteria. Most of the organizations that are currently listed are those that are organizations that we are aware of that are doing work around health equity or that are members of the Equity Advisory Group. I did mention that we will include a survey link that allows organizations to fill out their information so that they can then also be listed under that section. So we do want to give folks the opportunity to be listed under that section if they would like to be. All right, now then going to see if there are any other questions. So who is the user for the resource page? So the user for the resource page includes policymakers, but other stakeholders are welcome to use it as well. Now, when we talk about policymakers, we're also thinking about all of those stakeholders that are used or that are involved in influencing the policymaking process. So the resource page is going to be more comprehensive in the sense that we do want to provide a lot more information, not just for policymakers, but other stakeholders that could be using the information or sharing the information with policymakers. We don't suspect that policymakers themselves will be frequenting the page as often as other stakeholders who will then take the materials from the page and share it with state policymakers. All right, and I'm just going through and all right, so any thoughts to helping consolidate the large number of organizations working on this? That is not a role that we envision for the Equity Advisory Group. However, what we do see the Equity Advisory Group doing is informing the work of organizations and coordinating some of the messaging around health equity to ensure that we're really approaching the problem in a comprehensive way. And it may lead to a consolidation of organizations or a better coordination of organizations working on this task, but that's not a primary objective of the advisory group. And then there's another question that the social or comment that the social justice aspects of health equity may be complicated for policymakers. And we would agree that certainly is going to be a complicated topic to tackle for policymakers. And that's why this group is so important in helping to inform that discussion and that conversation so that we can address all of the issues that are necessary to move equity forward in the state, but in a way that is easier for policymakers to understand and in a way that is actionable through policy development. Another question is, have we considered or will we offer recommendations to policymakers or just data? And that's a wonderful question. We will identify policy options throughout the work, and if we get to a point where there is a good set of recommendations, we may consider suggesting those recommendations as well. So we certainly want to have a focus not just on the data, but also the strategies, the policies, the programs that can be implemented to advance health equity at the state level. And so if we feel strongly that there are some recommendations that can be made there, then we may make those recommendations as an equity advisory group. And then last question I see here is, will the group recommend resources to move health equity forward? Yes, the group will recommend resources. I don't know if this means funding or resource allocation, but certainly we will be recommending various resources that can be used by policymakers and other stakeholders to move the health equity group forward. Is the term equity and health equity being used interchangeably? This can be confusing. That's a great point. And I think that is something that we will want to discuss more as we come to a consensus definition around health equity. What do we mean by health equity, and how does that differ from equity in general? So our focus is going to be on health equity, recognizing that we do need to address all of the social drivers of health to address health equity, but we do want to be careful that we're not using it interchangeably with a broader connotation. All right. I don't see any more questions here, but I appreciate all of your attendance on this webinar this morning and for bearing with us through some technical difficulties. Hopefully it wasn't too painful for you all on the other side. We again are really thrilled that there has been such high interest in this equity advisory group, and are looking forward to the work going forward. And if you again have any questions, please feel free to reach out to me. And I'm happy to connect with you if you'd like some more information about the work that we plan to do, or have any other suggestions for the work going forward. Again, thank you so much, and we look forward to seeing you again in February. I will be sending out meeting materials prior to that meeting date, and we'll also be sending out a link to the resource webpage before it goes live for you all to just take a sneak peek at. And so you can offer some more feedback on that resource page then at that time as well. All right, have a wonderful rest of your morning, and we'll talk to you all soon.